Good evening, Dr. Fleming.
How are you tonight, Laurie?
I am good, and I am once honored again to be talking with you on our podcast. And I'm quite excited because tonight we are going to cover some questions on myocarditis, pericarditis, cholesterol, and do amino acids and vitamin C help with inflammothrombotic diseases, which is known as inflammation. So, to get started, can you tell our listeners what led you down the path of wanting to understand more about inflammation and heart disease?
Well, I joined American Heart in 1976 as the youngest faculty member, and at that point in time, I got placed in several committees. One of those had to do with cholesterol and heart disease. And so I became actively involved in teaching physicians and the general public about cholesterol and the role of heart disease. And I spent a couple decades from 76 to up until 1989 when I began my fellowship in cardiology, basically looking at cholesterol as the primary factor, or triglycerides and fats, which are also part of the cholesterol pathway. But in 89 to 92 during my fellowship, part of what I was very focused on was not only how to correctly measure changes in the heart and look for heart disease, but what were the causes. And that research ended up in adding to the knowledge base that I had. And then shortly after that, I really kind of sat down, took a 6-month period of time to look at everything that I could find at the time. Now, the internet was functional at that time, not nearly what it was today, but I probably went through about 600 or 700 research papers that were published in the United States and around the world. And I simply looked at all the different factors that people were talking about and tried to integrate those into what I called a unified theory. That's my physics background. We kind of try to think of everything as unified and figure it out and go through the details. And by 1994 at the Dallas American Heart meetings, I was presenting that and saying, clearly cholesterol and fats, triglycerides play a role, but there's an awful lot of things that the data around the world find. Biggest problem, we've talked about it a couple times before, is that people don't like to recognize, in many cases, the research work that other people do. And so part of the difficulty was getting people to recognize, wait a minute, there's work out here on lipids, cholesterol and triglycerides. There's work out here on fibrinogen, a clotting factor. There's work out here on homocysteine and lipoprotein little a. So, and viruses and bacterial infections and all of these roles. And I brought them together, but people don't want to look at other people's work if they can avoid it. Sadly, and there's a variety of factors for why that happens. But I'm trained as a research scientist, have been since 12, 13 years old was my research career, and I just think in those terms. So for me, if there's something that piques my interest that I think is important, as this was clearly one of those factors, I dig into it. I don't wait for somebody else to come up with the answers. Just like, dealing with SARS-CoV-2/COVID-19, it wasn't a matter of should I investigate it. It was, this needs to be investigated, it needs to be understood, it needs to be integrated. And clearly, it fell in line with the inflammothrombotic or inflammation, if people want to simplify it to that. But as we're going to see with homocysteine, you can't get away from the thrombosis part, because that's part of what is critical here. It's part of what the lipoprotein little a does, is that additional information on blood clotting or thrombosis. So it was a natural progression for me.
Well, I'm glad you started down that path. It's kind of, we fast forward into COVID-19 world, and we see that inflammothrombotic response going, on all over the place. So the next question I have is, what is the difference between myocarditis and pericarditis? Because we're hearing so much more of it right now.
Right. So anytime you hear itis, itis at the end of a word, it means inflammation, right? Well, what is
Yes.
inflammation? Inflammation is it's basically when tissue swells up. Well, why does tissue swell up? It swells up because there's something in the tissue that shouldn't be there that's irritating the tissue, whether that's your skin or your heart or your appendix. And the white blood cells of your body are coming in there to try to deal with whatever the irritant is. And that could be an infection. And in the process, releases a whole bunch of chemicals that kill off an area and clot an area. And because it's doing that, and to get more white blood cells in there, the blood flow to the area increases, at least up front in the early stages. And that's why if you see something on your skin, you'll see it's a reddened area because the blood flow is increased. That's why it gives that red appearance. So anything itis is inflamed. Myocarditis means the heart is inflamed. Pericarditis means the pericardial sac. There's a sac that sits around the heart, and there's a little bit of fluid in there. You can kind of think of it like the oil in your car. It allows the heart to move frictionless and to be protected. It's in this sac. And so if the pericardium, that sac, is inflamed, then you have pericarditis. And if they're both inflamed, then you have myopericarditis.
So would you say that pericarditis is the precursor then to myocarditis?
No, it just depends upon which area is affected. So for example, if you have part of the heart inflamed and you have myocarditis, it should be in a very specific area. It tends to show up in a very specific area. And so when we look at an electrocardiogram, the changes we see on the electrocardiogram, an ECG, or a lot of people like to call it EKG, you'll see a very localized area. Pericarditis, they don't necessarily need to occur together, and you can have one without the other. Pericarditis means that entire pericardium surrounding the heart is inflamed, and the electrocardiographic changes will show up throughout the electrocardiogram. And that's one of the ways to distinguish. Another way is that the number one sign for myocarditis on an electrocardiogram, because the heart is somewhat impaired and probably not functioning as well as it should, it's not squeezing as much blood out, the heart will compensate by increasing your heart rate. And so the first thing you actually see on an electrocardiogram is a rapid heart rate, what's called sinus tachycardia, or it's coming from the sinus node like it should be. It's going faster than it should be.
Okay. I found out something interesting talking to you this week and preparing for this talk, which I didn't know. I don't know if our listeners even know, but we were talking about the heart. It was interesting that you said that the left side of the heart faces the front and that the right side of the heart faces the back.
Just the opposite.
Opposite. Okay.
Yeah.
So right side faces the front and the left side of the heart faces the left.
Right. So if you take your fist, and typically your heart is about the size of your fist, and you look at this is the right side and this is the left side. And we got the terms because when the hearts were taken out of the body and first looked at, they were laid on a table. So they just sat there, right and left side. But in your body, what happens is the heart is actually rotated and tilted. And so the right side of the heart actually sits to the front, and the left side of the heart sits to the back. And then the blood comes out and down back by your spine. That's how the aorta, the major blood vessel, comes out.
Okay. All right. Makes sense. So the next question, I often hear my clients, that I'm sure you hear it as well in the cardiovascular world, that their doctor missed something on their test. So you talk about in your book that angiograms can detect the plaques that grow in the opening of the artery called the lumen. But you also say that it can't see diseased artery tissues, which could be why a lot of the doctors out there miss things wrong with the heart. Can you explain this? And then also, can you talk about the spike protein causing damage to that tissue as well?
Right. So I think most people, when they think about an artery to the heart, just think of it as a tube, just a tube that blood flows through. And
Okay.
that's really not correct. It's not correct, even though that's kind of how people think about it. It is a tube that blood flows through, but it's not like a straw that's fixed in size. The arteries of the heart are unique to the human body in that the size of the blood of your artery that the blood is going through tonight at rest while you're asleep is known as baseline. Now, a lot of people just refer to it as rest, right? But baseline. And so what happens is that the arteries of the heart, to allow you to get up and run or play tennis or play with your grandchildren or even do an interview like this, they have to carry more blood for you to do that than they do while you're asleep, because most of the blood, about 85 to 90% of the oxygen and the nutrients going through your arteries at night while you're asleep is being used up, which means there's only some 10% left. And that would not allow us to sit here and do this interview. So the arteries of the heart have the ability to relax and increase the blood flow to a peak of 5 to 6 times over baseline. That is called flow reserve. It's 5 to 6. Now, I'm in a unique position to know that because the man who wrote the equation on that for dogs is the same man who trained me, Kenneth Lance Gould. The man who wrote the equation in people is me. I simply took the world data, analyzed what we knew in the United States and Germany, and then ran that equation to determine what the variables were. And again, it's 5 to 6 times. So if your arteries are normal and you increase the demand, you walk on a treadmill, they will dilate, get bigger, and carry more blood flow, right? And that's what most people think of. They think of, okay, you have pain when you exercise, that must be coronary artery disease. And when we first started looking at this in the 1960s, the people that were having heart attacks, myocardial, that means heart infarction, death, or heart attacks, they got injected with angiograms. So we were injecting that area where the blood flows, and that's called the lumen, L-U-M-E-N. That's all it sees. And these people would have narrowings. But it turns out that about 85%, 70 to 85% of people who have a heart attack have no narrowing. It's all disease in the wall of the artery, and you may not see it. In fact, in the New England Journal of Medicine, I think it was 1989, Glagov, who was a Russian pathologist, published research for the first time showing people that had massive heart attacks, and when the arteries were sliced through, the lumen, the blood flow area, was clean, but the cholesterol and the fats that had deposited in the wall, you could then see under the microscope, but they didn't show up because the lumen looked normal. You didn't know it was narrow because it just got squeezed down even more. And so that was our first indication that many people who have heart attacks have this plaque buildup in the wall. And the reason why they get pain is because the wall is full of inflammation and thrombotic material that doesn't allow the wall to relax to increase the blood flow. And angina, that pain that you get from insufficient blood flow, isn't as much about insufficient blood flow as it is differences in blood flow from one area to the heart to another area of the heart. And we know that because in 2001, I presented at the American College of Cardiology measuring these different blood flows and showed that all we had to do was try to shift the blood flow, and a diseased artery couldn't improve and a normal artery could improve, but they were still just laying on a table, not doing any more work. And then when we made everything shrink back down with less blood flow, the pain went away. So angina is due to a regional blood flow difference. And you've heard me talk about this multiple times with Fleming method. This is part of what led to the research and development of this method of measuring differences in blood flow and metabolism. So it turns out that many of the procedures that we do share the blood. We don't actually improve the blood flow, which would be the ideal thing to do. We just simply equilibrate it from good area to bad. The overall flow to the heart hasn't improved, but you don't get the pain because the bad areas are now getting some of the good areas' blood, and the good areas are getting less, but there's no regional difference. And so your pain goes away and you think you're better. And sadly, it's unfortunate that most cardiologists and physicians don't have a better grasp of this, because it would demand that we do something to reverse the disease versus placating it by bypassing it or stenting it or laser or atherectomy or rotorblade, all the things that I've done in my life as a cardiologist. But the treatment to improving overall health and overall blood flow is to make the dietary and lifestyle changes that will take all that material in the blood vessel wall and extract it out, take it out, so that the wall can now function like it should, as opposed to leaving it in there and just bypassing around it and sharing good areas with bad areas, which means no benefit for the heart, but the pain goes away.
So have there been any has there been any progress? I mean, if you were doing this back like in the 1960s and 1970s and you knew that as a cardio doctor, has there been any advancements? Like, why don't these cardio doctors in today's world, 2024, why don't they know this? Are they not teaching it in medical school?
Well, so that latter part that I gave you, I mean, I talked about it at the American College of Cardiology, and that was, I mean, there were 5,000 physicians that were there, but they clearly heard more than just my hour presentation on that. They had 7 other 1-hour presentations they were listening to. And going back into practice, the reality is many people don't really care about the science. You know, you've heard me harp on this. PhDs solve problems, MDs treat problems, JDs cause problems. My youngest son is trying to get in medical college right now, and he's competing against people that just memorize and regurgitate, and he wants to fully understand it. And so he's having to wrap his brain around just memorize. And memorization is a great thing in an emergency. You know, it really has a critical place, but it doesn't mean you fully understand what it is that you're doing. You're just doing what somebody else has told you to do. And sadly, we haven't gotten very far in a lot of healthcare because of these types of problems. And a lot of the imaging that we do in healthcare is determined by who gets to bill for it. You know, when coronary angiograms were first done, they were done by radiologists, and it was only by accident that it was even discovered. So cardiologists couldn't do them, couldn't interpret them. Then cardiologists got to do them, but the radiologist says, no, but we'll interpret them. And the same thing with echo. When echocardiogram was done, ultrasound, the radiologist didn't interpret it. Then cardiologists could start doing it, but the radiologist had to interpret it. And then finally, the cardiologist could do it and interpret it. And that cash flow money shifted so that now we have things like coronary calcium scoring, which, again, shifted it so the radiologist could do it. Why is there an argument for coronary artery calcium scoring by cardiologists? Because cardiologists can now do it and get paid for it. The problem is it really has a very limited value because it's looking for calcium. It's not looking for the ability of that artery to dilate and get bigger. It's just looking for calcium. And, it's like looking for calcium with cancer. Why is the calcium there? Well, it's there because cells have died and leached out their calcium, and it has no place to go. So why do you see calcium with cancer? Because the cancer gets so big, it outstrips its blood supply. The cells die, they leak out their calcium, so you see calcium deposits. But that doesn't mean anything other than the fact that there have been dead cells there leaking out calcium. It doesn't help you much beyond that. But in a lot of the testing that's done, a lot of the decision making, it's what did you get trained with? Most people really do not have a huge interest in learning anything more than they did in medical college. That's it. For many people, they're done. The argument is their lives are too busy. And my argument is you can't use the argument that you're too busy to keep it up to date, to learn how to take better care of your patients and justify, well, I have too many patients to take care of. You can't provide the quality care, the up-to-date quality care, if you're not going to keep up to date on it. And so it becomes this battle. You get people, I have all sorts of physicians who come up to me who say, Fleming, you're just an academic, right? Well, academics treat patients. We do clinical cardiology, but we also do the research stuff. And some people, we're not going to mention their names, that one of them, the first thing he said to me was, my God, you're actually also a clinical cardiologist. I just thought you were an academic, right? You remember that. I don't know if you do or not, but
I do.
But it's like, duh, again, these are important take-home points about why things happen, what the motives are. I had somebody that was worried about prostate cancer the other day that I know, and his doctor felt a nodule, had a slightly elevated PSA, so he ordered an MRI. And my response was, why would you order an MRI? It is not a useful test for prostate. And I said, they won't be able to really tell you what's going on. And when it came back, it said, can't tell if it's cancer or inflammation, can't tell if it's in the prostate or by the prostate. MRIs have a use. If you have a bony structure and you need to define something in the soft tissue by the bony structure, there's a value. That's what MRI is useful for. Otherwise, you get a CT. And in the case of prostate cancer, you begin with an ultrasound. And a needle biopsy if you need to. But somebody was motivated to get an MRI. There won't be a question about billing fraud for them. It'll be, wow, great job. You generated this much money for the hospital by getting an MRI, and it didn't help the patient. So now what are we going to do? We're going to do an ultrasound with a needle biopsy. All right, there you go.
I think it's part of what keeps us in sick care. It's just that wicked circle that there's
there is. Look, when people are critically ill, we need to have a good handle on this. And medicine evolved from what are the critical things to keep people alive. We are now at a point in time where we need to, one, have a better method of finding out what's going on in the body. And we've talked about that. That's what Fleming method does. And two, we need to focus on making people healthier. And we need to focus on looking at the medicines that need to be used for a period of time, getting the dietary and lifestyle changes made, and then getting people off medications back to health. If we can't do that, then we can't do that. But we have got to do a better job of trying.
And you mentioned, getting people off of medication. I mean, I talk to people all over, and it's so rare that I ever have someone tell me that my doctor's trying to get me off of a medication. It's always they want to keep them on and give them more.
Yeah, I frequently get this response from people when somebody will come in and they're on, a dozen, 10, 20 drugs. And I will look at them and I have the same question for every drug. Why are you taking this? And you might be surprised, maybe not, at the number of people who say, well, I don't know, you're the doctor, don't you know?
Oh
It's
my
like, I
gosh.
know why these medicines are used. I don't know if you know why you're taking the medicine, and I don't know if your doctor is using the right medicine, or at least the medicine I would use for what you're doing. And it's basically helter skelter in a lot of instances where I look at people on that many drugs and I can't decide what is or isn't working for you because you're on so many things that I am looking at this and it's helter skelter. You know, it's that old movie. And so I have to begin the process of what problems are we dealing with, and then I systematically say, okay, we have to do, my apologies for that. We have to do one problem at a time, and we have to go through one set of medications at a time and work on that.
Well,
And
and
it
it's
takes a
the
while to do that.
interactions. And it's the interactions with the medication. You got to take something 6 hours away, 2 hours away, 1 hour before, with food, without food. It's like you have to develop a whole Excel spreadsheet in order to take medications. And I'm sure that there's a lot of doctors out there that don't even pay attention. But we'll get to the next question.
Sure.
So, why do labs like homocysteine, fibrinogen, D-dimer, C-reactive protein, why do they matter when you're looking at inflammation of the hearts?
So I would argue that not all of them do, but I know where you're going with that. So homocysteine is one of those components that when we're looking for inflammatory, and you'll just let me use that term since that's the one I'm trying to get across to people. And this is a good example for pointing it out. When you have an elevated homocysteine level, not only does it produce inflammation and cause white blood cells to come in, but it inhibits the breakdown of something called fibrinogen, which means it helps to form blood clots as a consequence. That combination is particularly dangerous. Lipoprotein little a is another test that, as we were talking about before we went on air, this is 30 years ago I presented this at American Heart. And 20 years ago that I wrote the book Stop Inflammation Now, and it was on 2020. And only this year, in this last 6 to 9 months, has the cardiology community been writing papers of, oh my goodness, lipoprotein little a is a risk factor for heart disease. Yeah, and it was 30 years ago. And what happens with lipoprotein little a is it's a lot like LDL, the bad cholesterol, except there are some changes that we can get into if we have time. And those changes cause lipoprotein little a to not only be, quote, atherogenic, form the plaques, but also thrombotic to form blood clots. So in both instances on those tests, you can see it's important to understand they're both going to cause inflammation and blood clotting, inflammothrombotic. CRP is an inflammatory marker. It's made by the liver, and there are some more sensitive types, high sensitivity CRP. I mean, I was in Chicago helping a group of cardiologists a number of years ago, and this young man and his wife came in, and his doctor had referred him to see the cardiologist because he had an elevated blood test, and their doctor had seen another doctor on 2020 talking about elevated CRP levels. And I had to look at him and say, you don't know who I am, do you? And the conversation went towards, I'm that doctor that your doctor saw, but your doctor had no idea that I was visiting here in Chicago to see you. So it's a marker of inflammation. There's a more sensitive one called HSCRP, or high sensitivity CRP, because CRP can go up if you have meningitis, an infection of the meninges, the covering surrounding the brain. It's like pericarditis, the covering surrounding the heart. Well, the meninges there's covering surrounding the brain, and that's called meningitis when you get that. And CRP will drive that up. So it's not very discriminating. But if it's not elevated, it rules out a lot of things. I would argue that D-dimer test is not a useful test. D-dimer test is a test that shows up when you have a big blood clot. And my response there is that if you have a big blood clot, like a big blood clot in your lungs, you're probably close to death. And if you need a D-dimer test to tell you that somebody is hypoxic, low on oxygen, turning pale, and have a big blood clot in their lungs, the person with the problem is really the patient, not the doctor trying to figure it out. So D-dimer is not very useful, and I would argue a waste of time.
What about with someone who had the COVID shot and now experiencing some heart issues? Would you say D-dimer is a worth
No.
for a one test?
No,
Okay.
D-dimer is one of those, I really don't know what's going on. Let's get this test. I mean, it really is not a very sensitive, useful test. By the time D-dimer is elevated, you have a problem, and you don't need a blood test to tell you that. Your doctor ought to be able to look at you and go, "Yeah, you're gasping for air. Your oxygen saturation's in the 70 percentile range, and you look like you're gonna die. Yeah, I think maybe we should be working on that instead of getting another blood test."
Okay. All right. How does LDL and high triglycerides burden our heart health?
Right. So we talked about cholesterol. Go ahead.
Right.
You want to add
Oh,
a
I was
question?
going to say one more time. So that lipoprotein little a, do you run that lab like one time, and is it more of a genetic marker? Like, could people
So
inherit that?
there is a question about that being genetically presented. There's also a tendency for women to have that go up as they get older, and men it goes down because there's evidence to suggest that estrogen also drives it up. So congratulations, ladies. Lipoprotein low A, like most things, the question is, why do you order it? Are you on a fishing expedition, or do you think you should be looking for it? Now, if you have somebody that you think has heart disease, you should be running tests to see what potential risks does this person have that could increase the risk of dying, that if I treated it would reduce the risk of dying, right? I mean, that's the reason
Okay.
for getting a test in this case. So lipoprotein low A is, so let's back up. Let's look at these things that we use these abbreviations for, LDL, HDL, that type of thing. So when the work first started looking at cholesterol levels, they would draw blood from people, it goes to the lab, they centrifuge it, right? And the heavy things go to the bottom of the tube, and the lightest things go to the top of the tube.
Okay.
It's
Makes
like
sense.
oil and water, right? Okay.
Right.
Yeah, not any more sophisticated than that. So the heaviest stuff had the highest density, and it's called high density lipoprotein, HDL.
Ah.
The next layer, which is typically just about zero, because it only lasts for about 2 minutes in your body, is called intermediate density lipoprotein cholesterol, IDL, and I'm willing to bet most people haven't heard of that. And then right above that is the lower or low density lipoprotein, and above that is the very low density lipoprotein, and above that is what's called the chylomicrons, which looks like milk. So those are the basic types of cholesterol we talk about. None of them are completely cholesterol or completely fat. These lipid molecules that we talk about, LDL, IDL, HDL, VLDL, chylomicrons, have varying amounts of fat, triglycerides, cholesterol, and proteins. The proteins primarily identify what it is. like the spike protein of SARS-CoV-2, connecting to the ACE2 receptor, saying, this is me. These lipoproteins, LDL, IDL, HDL, VLDL, chylomicrons, have proteins attached. Some of them are called apolipoprotein A, apolipoprotein B, apolipoprotein C, apolipoprotein E. They tend to be connected with different ones. C tends to be more associated with the fats. Which ones are the fats? Well, fat floats, right?
Right.
So if you're looking, that would be the very low density lipoprotein cholesterol and the chylomicrons. In fact, chylomicrons look like milk. And I've had patients whose triglycerides were over 5,000. And when you draw their blood, that red blood that you normally see looks like tomato soup that's mixed with milk. And that will get your attention when you see it the first few times, right? And that's not a good thing. LDL cholesterol tends to have apolipoprotein B on it, or some version of it. And HDL, the stuff that plays scavenger, tends to have apolipoprotein A attached to it. And in each of those cases, those proteins not only identify what they are so the cells of your body know what they're taking out, they also activate certain enzyme pathways that cause the shift from one type to the next. Okay? So that's their function. Lipoprotein A looks a lot like LDL, and LDL has its apolipoprotein B. But lipoprotein A also has the apolipoprotein A attached to it. And that's where it gets its term lipoprotein little a, with parentheses. And it promotes that increased deposit and blood clotting, which is why it's such an issue. All right. So I ran through all of that, and I know I haven't really completed your question. So what you were talking about, the plaque deposition, right?
Yes.
Okay. So your brain runs on glucose.
Correct.
Period. Your heart will run on glucose or fats. Now, there is a benefit to that, because if you look at fat, there's 9 kilocalories per gram.
Okay.
Everybody says calories, but it's really kilocalories, 9,000 calories per gram, right?
Like vitamins and
Not
vitamins.
9. Yes. If you look at proteins and carbohydrates, they have 4,000 calories per gram, 4 kilocalories per gram.
Okay.
And alcohol has 7, right? So one way to think about this is, what do you want your heart in an emergency to be able to tap into in an emergency? Would you like it to be able to tap into something that's going to give it 9 kilocalories per gram, or something that gives it 7 or 4? I'll save you the answer. It's 9. You want to get as much calories for your heart as possible in an emergency, so that if you're on the Serengeti running from a lion or tiger or bear, one of the jokes I used to point this out to my students is, what do you call the guy who runs on carbohydrates or protein? Lunch. Because he only has 4,000 kilocalories versus the guy running on fat at 9,000 kilocalories. The one running on fat is going to have more energy to get away, right? So
Makes sense.
There's the mechanism of why it's beneficial. But like everything else, humans have pretty much well managed to botch it up. A system that runs efficiently only runs efficiently unless you abuse it. And what we have done with our diet and our lifestyle is we've overindulged. It doesn't matter whether the calories come from fat or processed foods. Too many calories make fat. Too much fat Okay, so it goes to the arteries where it needs to be there for an emergency. And a little bit, not so bad. But when you keep depositing and keep depositing and keep depositing, and you don't use it up, it builds up in the wall of the artery. That nice elastic artery of your heart that's supposed to open up and carry your blood flow 5 to 6 times at peak flow can't do it as well anymore because there's junk in there preventing it from really moving out. It's got a limit, and now it can't relax because there's garbage that you've built up into it. And your body knows it shouldn't be there, and your immune system, your white blood cells, go into the arteries and say, let's take the garbage out, right? And they do that. And they can do that for a while. But if there's too much garbage that's built in, those white blood cells go in, and they have to get in through something called fenestra, little openings between the cells. So they can slide through. They're very good at that. But like an octopus, if you will, going through tanks, it's very flexible. But once the white blood cell eats so much fat and cholesterol in the wall of the artery, it's no longer flexible. It's stuffed, and it can't get back through the opening. And once it's stuck like that, it will die. And then it becomes hardened. And if it dies, it may show those calcium deposits. But if it doesn't die for a while, it sits there. It tries to survive. It tries to figure out how to get out of the wall of the artery. It can't. You're not using any of it up. You haven't made any dietary and lifestyle changes to get the garbage out. So you're continuing to put more in. More white blood cells come in. More of them get trapped. And what happens over the course of time is that if you get a lot of those white blood cells in there, they prevent the walls from relaxing to carry more blood flow when you need it. So you start to get chest pain because there's differences in the regions of blood flow, and now you can't exert yourself because it can't get there. And you haven't even narrowed the lumen part yet. You've just interfered with the ability of the artery to do its job, which is to relax and carry 5 to 6 times as much blood at peak as it does when you're asleep at night. So those cells stay there. And that is called an atheroma, atheroma. And that is what we call a soft plaque. It looks yellow. And when we look by laser scope in the arteries, when it starts to bulge into the lumen where the blood is flowing, it looks yellow, like a pimple, because in reality, it is, right? If those cells die, they will release their calcium, and they will form a scar with the calcium. And so when we look at those with angioscopy, this laser scope, they look gray. Now, they're pretty hard, but that also means they won't give a lot of take in the wall of the arteries. What happens is eventually they will there won't be any more room in the wall for them to grow. They will stretch the wall out till the wall can't go any further. Then, and only then, will they grow into the lumen where the blood is flowing, which is why coronary artery disease and everything that can rupture is happening in the wall. And it's only in the later stage of disease that we see this narrowing occur in the area where the blood is flowing, because there's resistance to growing in there because there's blood pulsing through there. There's no resistance to building out on the wall because it's just a wall of muscles and connective tissue, and it will stretch until it can't stretch anymore like a balloon, and then it can only go in. And what happens is that it will get into the area where the blood is flowing, the lumen, and it will rupture. And your blood vessels interpret that as, wait a minute, I just had a rupture in my blood vessel. Well, normally what happens is we see cuts on the skin, right? That's a rupture in a blood vessel. And what happens when you rupture a blood vessel? You're hoping it will form a clot so you won't bleed to death. Well, the same thing happens inside the blood vessel, the coronary artery. When it ruptures, the message is, oops, we're bleeding to death, form a clot. And when that clot forms, it stops the blood flow. You don't bleed to death, but what happens? Everything downstream is deprived of blood and it dies. And you have a myocardial heart infarction death.
You know, I think it's the first time I've ever heard any doctor explain it like that. And I've sat with a lot of heart doctors, just family members. It's crazy how that is not even out there.
I'm always stunned by what lack of understanding there is, but we went through this already. Most physicians memorize and regurgitate. That has a value in an emergency situation, but a failure to better understand what's really going on compromises the quality of healthcare. We dealt with this with people that were put on ventilators during, quote, COVID, right? 3 major ventilator committees in the early 2000s published reports. So these aren't minor reports. These are reports that if you're a physician, you should read if you're using ventilators. They're important. The committee says if you have fluid in the lungs of a patient, acute, sudden, respiratory, lungs, distress syndrome, right? I have no idea why they did that.
I don't either.
Build up in fluid that puts you at distress. You have to give patients half of the tidal volume, the amount of air you give them each time, that you normally would, because you no longer have a normal elastic lung. You now have a lung with fluid in it, and the research has shown painfully enough that all 3 major ventilator committees reported the same thing. If you give the standard amount, you will kill the patient. And when doctors tell me they don't have time to keep up on things, my response is, your patients will die if you don't. And we proved that quite outstanding, I think, right? I mean, we saw this repeatedly despite the warnings 15 years before COVID. Don't do this with the ventilators on these patients. And yet the chaos that occurred was nobody was up to speed. They hadn't read reports from 15 years ago. But LP(a), it's been 3 decades. It was 30 years ago. This is 2024. I presented at American Heart in 1994. 30 years ago. There is no excuse.
You spoke last year. Was it last year at the American Heart Association when you were in Florida, or was that 2 years ago? Right before the vitamin C conference.
Thank you. So I was at the American Society of Nuclear Cardiology, and I think it was not last year, but the year before. I think it was 2022. And it was very interesting because this is where the nuclear cardiologists from around the world come once a year. That was where the meeting was. I was in Orlando before I drove over to, wherever it was I drove to.
The vitamin C conference, yes.
Right. And we presented the research of what the study had shown which drugs worked. And there was not a single nuclear cardiologist or others that were there who looked at the information and said, well, those drugs can't work. That was not their response. Their response was, looked at the data, looked at the images, looked at the results and said, I guess those drugs work. I mean, there's measured data. There wasn't any hesitancy. And this is one of the reasons why I argue repetitively for the need for objective data to drive home the point that we need to drive home, at least from my perspective as a research scientist, that if I am going to explain to somebody what's going on, and I'm going to tell them that something does or does not have an effect, work or doesn't work, I need to be able to prove that. I have a moral and ethical obligation to do that. And I view this from both sides of this discussion. If I think I have something that works and I do not prove it, and I'm right, people will be denied that test or treatment because of that, and they will die. And I view that as being on me, because it's my job to prove it. If I think something works and I find out it doesn't, and people get that treatment and they die, it is also on me, because I had an obligation. Patients expect us to tell them the truth. You know, these titles, PhD, MD, JD, they mean something. They mean what they were supposed to mean. What they mean to me is that I have gone through the education, I have put in the time, I have developed the understanding, and I've accepted the responsibility of this mantle, so that when you ask me a question, you should be able to trust me. You should be able to trust that. The failure of the system doesn't mean that the degrees are useless. It means there are a lot of people with the degrees that are failing in their job.
Dr. Fleming, I wish there were more doctors out there like you. So, just a quick question. You go to the all of the functions and these talks. If you had to guess, how many other doctors are there out there like you who are that driven into research that they really are true healers and not just after the next dime?
My personal experience is fewer than 5.
Which
And
is
I don't
sad.
want to say that just flippantly,
Yeah.
because I'm not patting myself on the back. This is not a matter of doing anything like that. The reality is I take this very seriously. You know, maybe it's because I started at such a young age. Maybe it's because I watched so many people looking for answers that didn't get them. Whatever all the factors were, I take it very seriously, and I think everybody should.
So if there are any doctors listening on our talk this evening, what is one thing you would like to just tell them right now?
Well, I think that my response would be, I'm not sure if I'm telling them something as much as asking a question, is to genuinely reflect on why you're doing what you're doing. And I used to always teach my students that people can make mistakes. And there's going to be lots of lawsuits for everybody, because speaking as a lawyer, lawyers love to sue people, right? No, I don't, but the reality is I think a lot of people get into it just because they want to show somebody that they can, you know, beat them up. And they can do that legally. But I would always teach my students and anybody else, I would say, treat your patients the way you would treat your mother, your father, your husband, your wife, your sister, your brother, your children. If you can look at the scenario and you don't have answers, you should dig for those answers. Whether that's individually or with your colleagues or any of a number of things, you should dig for those answers so you're doing the right thing and do that right thing. And you may end up in court with somebody trying to sue you for medical malpractice, and the system may be broken. But I honestly believe that the vast majority of people will listen to you, and since none of us are perfect, I mean, what was it? Gandhi said, being imperfect ourselves, we should remember to be kind to others. Taking that into consideration, if you can look at people and say, what I did, I would have done for my mother, my father, my sister, my brother, my husband, my wife, my children, I think that the vast majority of people will look at that and go, did you hear that? We're not a number. We're not just somebody through the system. They tried to get the information. They did the very best they did. I was there when HIV hit, and we were struggling, and we collected data as rapidly as we could. And we had to look at people and say, we don't know if this is going to work. All I can tell you is that if you were any one of these people that I just rattled off and you were here in this bed, this is exactly what I would do for them. I'm doing for you what I would do based upon the knowledge base I have for the people I consider most important in my life. How can I do better than that for you? There's not a better than that. So if you are a practicing physician, and this is you need to reflect on what you're doing, the amount of time you are investing in understanding what you do not understand, and do the right thing for your patients.
Very well put. I just want to make an announcement. We're going to put the call-in number up, and Dr. Fleming and I will be taking calls. So we'll put that number up here in just a few minutes. That was very well said, Dr. Fleming. I'm going to ask the next question. So protein is all the rage right now. You're listening to a lot of these podcasters, and they're talking about protein. So I understand when people go on a ketogenic diet, we'll say, that they're taking out all of the inflammatory foods. But what I'm not seeing or hearing is these podcasts are showing the blood labs, like what's going on with LDL and HDL and triglycerides and total cholesterols and lipoprotein(a). So in your book, Stop Inflammation Now, and Leighton, if you could put that book up, I'd appreciate it. In Stop Inflammation Now, you talk about the different type of diet phases. And I say phases because you're not asking everyone to stay on the phases for the rest of your life. You're asking them to stay on the phase until you can see a difference in the markers that are important for heart health. So 1 and 2, your phase 1, your diet plan 1 and diet plan 2, they showed good numbers. Their LDL came down, lipoprotein came down, their total cholesterol, the C-reactive protein, the homocysteine, they looked phenomenal. Diet 4, which was higher proteins, had increased C-reactive protein, increased LDL, total cholesterol had tanked. So can you explain this? And I'm going to put myself out there because I personally had never heard of lipoprotein(a). None of the docs that I work with have told me about it. So I was going to run cholesterol panel, and you told me to run lipoprotein(a). I was shocked because I consider myself a pretty healthy, self-conscious eater, and I think you're well aware of that. We've had enough dinners together. You like him to be at 50, and I was at 80. but my LDL was 148, and I was shocked. I immediately went to phase 1 of your diet, and within 30 days, I had dropped my LDL 21 points. So, can you explain to me, is there any difference? So, you wrote that book back in 20 years ago, 1994, was it?
Yeah. So the theory came out in 94 and the book came out in 2004.
Okay.
10
So,
years after.
2004. So now fast forward, we're into all of this regenerative farming. And these farmers are doing so much better. They're not, spraying all the crap, all the herbicides and the pesticides. They're not feeding them the corn and the grain and all the stuff that, ends up in our bellies as well. So now there's grass-fed, grass-finished. So I run into a lot of people. I talk to a lot of people. Someone wanted me also to ask this question tonight. In today's world with grass-fed, grass-finished, high-protein diets, what do you believe is still, is it the same? They're going to see the increases in LDL and inflammatory markers like CRP and homocysteine?
Right. So let's separate the arguments. I mean, one of the arguments is it better to try to do something more what you think naturally occurring versus system driven to try to drive up the fat content on the animal to then sell it at market. So the difference between grass-fed and corn-fed type thing. So that's one problem. And part of the difference in that will probably be the amount of saturated fat or marbling to the animal, which is obviously going to be higher caloric and the saturated fat part of it. But independent upon what the animal is eating, there are a cow is a cow is a cow. A bison is a bison is a bison is a bison. They are genetically very specific. They are different from each other. They have certain proteins. The land animals have proteins that we do not have as humans. You can take that and run with that in whether it's a theologic argument or an evolutionary argument or whatever you want to do. Humans are different than the land animals are. One of the differences is something known as NER5AC. We see these animals as something foreign to us when we eat them. The consequence of that is an inflammatory thrombotic response. Obviously, the more you eat, the more response. The less you eat, the less response. There are some animals, like fish, that don't have that. So they're not antigenic. They're not different. They're not like the SARS-CoV-2 virus feeding something into us that is foreign, which, by the way, that NER5AC receptor is what that virus attaches into. So those become two issues. One is simply the fat load, and the other one is the antigenic, unusual protein that your body is going to say, wait a minute, that's not us. And it's going to react to that. One of the problems, the blood tests are a peripheral downstream marker of what's going on. And we've talked about this before, and I published on this, that we looked at in the early 2000s, quantitative measured nuclear imaging using the early versions of FMTVDM or Fleming method to measure the changes in the blood flow and metabolism. And we compared that with all of these blood tests, all the ones that you mentioned except D-dimer, which we didn't do. I wasn't looking for a pulmonary embolism, right? And it turned out that up front, the amount of disease that we could measure with the imaging and the amount of disease that showed up in the downstream blood tests didn't match. So using those alone or using your change in weight alone doesn't give you the answer to the question you have, which is, what's this doing to my heart? What's this doing to my brain? What's it doing to the tissue of my body? Now, what did happen is that as we then repeated those tests over time, the quantitative nuclear imaging was spot on. And the blood tests tended to track the same direction. If they got better, your heart disease got better. If they got worse, your heart disease got worse. But it wasn't it was a correlation that allowed you to track it. So once you have those blood tests, and it's very useful to have the nuclear imaging with it, but you can't get it right now because I'm not licensing it to people because I've been busy with some of this other stuff. Then, once you get that information, then those blood tests will track and they will tell you. If they're getting better, you know that the heart disease or the brain disease or the kidney disease is improving. But if they're getting worse, you know that the others are getting worse. And the goal of what we were doing with those early studies, which were in the 2000s, late 2000s, was I wanted to know, okay, putting this entire theory together, what happens to all of this along with the measured outcome on the nuclear imaging and the weight and everything that people tend to peripherally look at? How did all of this compare with these different dietary regimens? And, the results turned out what they were, which were the high protein diets saw increases in homocysteine, increases in blood clotting. Could you lose weight? Absolutely. But, other than that, and you can see, you can go on any diet you want. I had a roommate when I was first going to the University of Iowa. Jim was his first name. I won't give you his last name. He worked in the cafeteria system. He went on to be a physician's assistant. And every time Jim wanted to lose weight, he would eat nothing but ice cream. Okay? And Jim would lose weight. He worked in the cafeteria. He could get all the ice cream he wanted, unlike other people. The difference is that when Jim started his diet, his bowls of ice cream were this big. And when he was done with his diet, he was getting something about the size of a drop because he got sick and tired of it. And one of the phenomena of any, quote, diet is that people tend to cut their calories and they tend to get tired of the foods on the diet. So they lose weight. And every time you lose weight, you will see up front, that means you're pulling on those fat stores. And so most diets, if all you do is look at weight and the fat, the cholesterol and the triglycerides, you will see both improve. You can go on a cardboard diet and you will see your weight and your fats and cholesterol improve. The problem is that if you track those for longer than the published studies that most people do, you will see they both go back up. Now, that probably wouldn't be the case on a cardboard diet, but you'd probably be dead on that one because you die, right? Because there's nothing in that you're going to use for it. But on all these other diets, you see these initial improvements on blood work and weight, but not on the nuclear imaging, because again, they don't match. They'll trend the same direction, but the blood test and the weight do not tell you what's going on at the heart. Gil Hansen was a personal friend of mine. When I was with the police department in Waterloo, Iowa, and Gil Hansen was assistant chief of police, and he was also Mr. America and I think Mr. Universe. He had zero body fat or darn close to it, muscular, and he dropped dead from a massive MI. But he sure looked good in the pine box.
Okay. That's going to be a disappointing answer for some of our viewers, but I get it.
Again, my family is in the food industry. Fleming Steakhouse, P.F. Chang's, Fleming Foods, Vikings are into food. If you want to buy the stuff, my family or some of my relatives will be happy to sell it to you. This is not an emotional thing for me. This is just a recognition of the facts. The only way I can go to make people healthier is to be objective. And again, that's one of the benefits of FMTVDM is it's objective. It doesn't care what you want to see. It doesn't ask, what do you think you see? It provides values that are measured like a ruler. The ruler works. It doesn't care whether you want to be taller or whether you're under height.
Under height?
It's going to give you that result.
It's always cute when you say under height. So we have about 500 listeners right now. So for anyone that wants to call in, the call-in number is up. It's 385-899-2134. But I'm going to keep talking until I've already got some email questions, but I'm going to keep going with the questions. So if you want to call in, talk to Dr. Fleming, the number is up on the screen. So the next question that I have, and I know we're kind of short on time because I've got some email questions people have already sent in. Does vitamin C help to support cholesterol by lowering it?
So what vitamin C really does is it's an antioxidant. So when something's oxidized, you can basically think of it as rusting, right?
Yes.
I mean, that's what iron is iron oxide. It's oxidized. And it's an irritant. So again, oxidative damage is part and parcel of what can cause problems. And with too much oxidation, it can actually make the cholesterol plaques more irritative. So the benefit of vitamin C or any of the antioxidant compounds is that they help with that oxidation process. They undo one of the components of the cause for inflammatory thrombotic response and lower that component of what's playing a role. So, it's removing some of the fire, some of the heat, some of the wood from the fire. It's not putting out the fire, but that's how it would have a benefit because all of these factors play in together. And this is one of the reasons why there's not a single answer for just everybody, because with all the people that are out there, the role that cholesterol or fats or homocysteine or fibrinogen or lipoprotein little a or infectious diseases or trauma inside the artery or oxidative damage or any of a variety of things plays a role is different from person to person. And how their immune system is responding to that is different from person to person. So I used to try to explain this, particularly to my sister, to think of it like a spider's web. If you tug on the spider's web, the spider is going to know something is happening and it's going to know where. And the more you tug on it and distort it, the more obvious that's going to be. But every one of these factors is a part of the spoke of that spider's web. And if the more of those you tug on, the more you're going to distort the spider's web, the more damage or disease you're going to have.
Okay. I want to go back to my last question when I was actually throwing myself under the bus. So back to phase 1, phase 2, and those diets that you saw such,
right.
Their numbers look so much better. So plant-based fruit, vegetables, a white potato here and there, sweet potatoes here and there. Why is that? Is it just because you're removing the meat and the fish for that short period of time?
Well, you're doing several things. And just for the record, phase 1, phase 2, Fleming diet, I did not name that. I thought fruits and vegetables covered it, but somebody decided it had to have a name. And I literally said, "You're kidding. People don't know what fruits and vegetables are. You go in the grocery store, those are all the bright things that are on that one side of the store that you don't visit." The reality is, again, we eat a lot of processed garbage, right? And the only thing you can say about that is it extends the shelf life of the food, but not of the person eating it. The reality is that fruits and vegetables and that type of food, removing the pesticides and all that garbage, which, again, that's a separate issue, are healthy. There's nothing in them other than antioxidants. There are proteins, carbohydrates, and fats to varying extent. They're filling. They have good fiber content. That's helpful for your gut flora. They have vitamins and minerals in them. And odds are you're not going to be able to consume enough of that to keep the weight where it's at. And so what you will do then is your body will start looking for those fat sources, and they will draw on those fat sources, and they will do it very effectively, which is one of the reasons why, if you're not having chest pain, or I don't think you are critical to have a heart attack, I will not put you on a statin medicine, using that garbage can term that people do. And the reason for that is most of the cholesterol you make in your body is made by your liver through the enzyme pathway HMG-CoA. So these are HMG-CoA reductase inhibitors. They block the liver from making cholesterol, which artificially lowers your blood test, and you think, waha, it's better, so I can eat whatever garbage I want to. No. I want your liver will make about 1,000 milligrams of cholesterol a day. The average person consumes 250 to 500 milligrams per day. You absorb 10% of that. So in other words, 25 to 50 milligrams per day. Your liver makes 1,000 per day. What I'm doing is depleting that input so that your liver will go get that cholesterol and triglycerides from the stored areas that are causing harm, because it wants to make cholesterol. Actually, what it makes is VLDL cholesterol, which is basically fat, which then gets turned into LDL cholesterol, the cholesterol part. So your liver wants to make that. I want it to make this. I mean, we've talked about this as far as treating people with the SARS-CoV-2 virus and genetic vaccines. I want your body to do its job. I want it to make what I want to get rid of, so that your body will deplete it, get rid of it. And the only place it can go get it is in the arteries and places of your body that it shouldn't be, that there's an excess of. It will go get it, bring it there, make it in your liver, and recycle it. And by not giving you that extra calories, saturated fat, and cholesterol, your liver will spend its time pulling the garbage out of your body where it's been deposited and use it up. And you'll have all the benefit of the antioxidants, vitamins, minerals, fiber, everything else, along with the proteins and carbohydrates that your body needs to run on for this period of time. And as you said, this is not a lifelong plan, or maybe it should be thought of as a lifelong plan, because it's extending your life. It's getting rid of the garbage so that you can have a life again that's worth living, not just one that you're ebbing out time, unable to do things because of the buildup of this garbage in your body, but a life that is, again, vibrant and worth living. We talked about prevention and getting back to health. We've lived for, 60, 70 years as a country with indulgences. It may not feel like that to people, but go back and talk to somebody who lived through the Great Depression or during World War II. And I think that they would differ with you in the opinion about just how decadent, and over the top our society has become. Less active, more garbage. It promotes the problem. So by providing everything beneficial for your body and basically signaling for your body to go get the garbage out of your arteries and other places and use it up. And then there's the other thing. There's also the issue of diabetes, because you're bringing down the calorie count, right? And you will be driving down. Most people that are diabetic are overweight. they have more insulin pound for pound than I do. They're not the kid with insulin dependent diabetes whose pancreas can't make insulin. They're making insulin, but the cells of their body have been so satiated, so saturated with extra calories and extra fat that the cells no longer respond to the insulin. And so what you see is the insulin goes up, and you see the insulin growth factor 1 go up, which I know you've seen in the book. And as the consequence of that, you're driving not only, IGF-1, insulin growth factor 1, which looks like insulin, is what's called an anabolic hormone. It's something that builds tissue. It says, I've got enough, I've got more than enough material, I'm going to build more. I'm going to build fat, or I'm going to build cancer, I'm going to build something, but I've got this extra material and I'm going to build something with it. Well, by depleting those calorie sources, and particularly the fat ones, so you have to go get those calories and suck them out, you'll literally, the cells of your body will say, wait a minute, I don't see as many calories floating around as I saw before. My insulin receptors had better get more tuned, more sensitive, and you reverse that. And I've taken people that had diabetes or high blood pressure. I've taken pilots that were grounded because of their health problems and people with heart disease and CVA strokes and diabetes, and improve their health by putting them on these programs, depleting the garbage in their body, getting the insulin and insulin growth factor down, decreasing the clotting tendency by getting a much lower homocysteine level, so it wasn't promoting blood clot formation, by not irritating the nerve 5 AC receptor, causing inflammation and blood clotting, and allowing their body to get back to being a body that's no longer impeded by the diet and lifestyle that they've been living.
That was a great answer on that. Thank you for that. We're getting short on time, so I've got a couple questions. I'm going to kind of bypass a few of these, and I can always come back.
Oh, okay. It's a coronary jump.
Yeah.
And let's take a few moments if people are willing to answer some of those questions. I don't want people to feel, yes. Okay.
So I have a couple of questions, but I have a couple of, let me just ask, and maybe you could just be brief on your answer. If someone received the shots and now his heart is now having heart issues, do stents and bypasses fix that issue?
So my first blush response would probably be no, because it doesn't deal with the underlying problem. Again, stents and bypasses take areas with good blood flow and shunt them to others. But if there's an inflammothrombotic response that's occurred because of either the virus or the genetic vaccines, then that needs to be addressed directly. And that needs to focus on dealing with whatever inflammation and blood clotting is going on, versus just bypassing or trying to crack open that artery, which is what a stent does. It doesn't solve that underlying problem. The other question is it just in one area of the heart? Is it this myocarditis, which means the muscle function is impaired? Or is it a blood clot issue in the artery itself? And independent of what the cause is, you kind of have to go back and take a direct look at that and focus on that directly. But my gut response would be, where it may make you feel better, it does not solve the underlying problem, nor does it solve the recurrence of that underlying problem.
Okay, next question. How does the COVID shot harm the heart? And if someone doesn't have the shot but got COVID really bad, is the spike protein equally as bad for the heart?
Right. So it's the spike protein that we know causes this inflammation and blood clotting, this inflammothrombotic response. So there's no doubt that different people respond different ways. Just like I said, with all those different factors, it's going to affect different people. Usually what we see is somebody who already has some level of problem, disease in their arteries, that this becomes that additional factor that simply makes it too much for their body to handle. And that can be either from the viruses or from the genetic vaccines.
Okay. A couple of the email questions. And for the listeners out there, thank you for holding on for Dr. Fleming and not going anywhere. The call-in number to ask Dr. Fleming questions is 385-899-2134. We've got about 10 minutes left, and then Dr. Fleming is going to tell us a little bit about his new book coming out. So one of the questions that somebody emailed in while we were waiting is, how effective have vaccines been against emerging variants of COVID-19?
Well, I would say probably not effective at all. The reality is most people have heard about pressure selection and antibiotic resistance, where if you keep exposing, in the sense of bacteria, that bacteria to the same antibiotic, what you do is you breed out resistance, so the antibiotic no longer works. The same thing's true with the genetic vaccines that are being promoted. We're trying to produce, in most cases, a specific type of spike protein, just one part of these viruses. Most of the original Pfizer, Moderna, Janssen, AstraZeneca, all the brands that were out there, focused on the original SARS-CoV-2 Wuhan HU1 spike protein. And what that did was it allowed the different variants to emerge. And you saw this if you were looking at the data over the past several years and or listened to the presentations I gave, where I show when these shots came out and the variants that occurred and drifted. So unless you want to, play the dog chasing the tail game and constantly go after the new variants that are there, somehow thinking that the virus is not going to continue to drift away from that. If you want to continue that approach, you're certainly entitled to do it. It's a semi-free society. But what we do, and you've seen this every year with the influenza vaccines that people use, and those aren't even genetic vaccines where they take the entire virus as opposed to just part of it. Over the course of time, that shift means that those prior vaccines aren't very helpful. And in the case of these genetic vaccines, we didn't even try to make the whole virus or the nucleocapsid, which is the part that we're best at making an immune response to. They chose the spike protein. This is chasing the tail. And most of the benefit that has probably occurred has occurred because of all the people that have been infected by the virus from person to person with all the parts of the virus and now all the variants of the virus. And there's, it's hard to understand the logic of someone who would say you get a better immune response from a genetic vaccine to a single spike protein than you get an immune response by getting exposed to somebody who's sick with all the variants, with all the parts of the spike protein. I mean, that just flies in the face of how immunology is practiced.
Okay. I have another email question somebody wants me to ask you. What are your thoughts on nanokinase?
So nanokinase is a soy product, and there are a lot of people that talk about it being beneficial, but there's no proof of that. There's no research that's been done that said, I'm going to take these people, they've been infected, I'm going to give them nanokinase, it's now having this effect. None of that research has been done. And there's a lot of people that want to have an answer, but it's our job as physicians to do real solid science. I addressed this earlier on in the program, that we have this moral and ethical obligation. I think when you listen to one of us talk and somebody says this works, you expect that they've done this type of research. when they really haven't. And there's also the additional side effect of knowing that soy products have different effects on different people. I mean, I've studied the effect of soy products, soy protein, on women with breast disease, whether that's breast
Right.
cancer or early changes. Some women get better, some women get worse. So, in the absence of some real research that's been done that says, I've taken these people, I've measured their spike proteins, I've given them nanokinase. Now the spike protein is no longer there, and compare that with people that have the spike protein, you don't give them nanokinase, and you look at it and say, well, it's still there. Is the difference that you think you see because this is the natural cycle, or are you really having an effect? And if you can't prove that, then you haven't proven it, and you have not been upfront and honest with people when you say, take this. And I've listened to people promoting it, and I've also listened to them give that. It's like watching a drug commercial on television, that they run all the caveats at you at the very end, where they'll say, well, research really hasn't been done to show this, but buy it. I'm sorry. There's a lot of really good research that's been done with niacin and vitamin C and other drug compounds that have shown an actual benefit in the treating of these viruses and these genetic vaccines, in contrast to something that hasn't actually gone through the research. And for as long as nanokinase has been promoted, they've had time to do this research. They haven't done it.
Okay,
That's on
so
them, not me.
a follow-up question to that. If someone, so since it's a soy product, if someone had a sensitivity to soy and a doctor is saying, hey, let's try this nanokinase, does having a food sensitivity to soy, would they be affected by nanokinase?
So I can tell you that it's a soy protein byproduct. I do not know, because I have not done research to look at this, how many people that are soy sensitive would have an adverse effect by taking it. One would think there would be, but
Right.
in keeping with the same principles I just laid out, I haven't done that type of research, but it would be something you could do relatively easily. You take
Okay.
people that have documented soy proteins, give it to them, and see if they react.
Sounds painful. There's another question that just came in. What about the nicotine patch for long haulers? What's your opinion? Do they work?
Right. So my response is, what about the nicotine patch? There's been no published research that shows that the inclusion of nicotine has any effect on anything as far as the virus or the genetic vaccines. I've listened to people promote it. It's the same answer. There's been no data, no proof of this. The fact that you may have something that sounds like a possible mechanism for how it might possibly work doesn't mean it's going to work. One time out of 10, when Big Pharma puts major money into doing research on a drug because it should work, one time out of 10 it works, 9 times out of 10 it doesn't. And there's nothing in nicotine that would prevent the attachment of the spike protein or the inflammothrombotic response of the spike protein. It falls in that same category. Something that hasn't been proven. And, again, you've heard me, I go on both sides of this. The remdesivir data is not compelling. The mononuclear antibody data now is no longer compelling because the spike protein has changed. There's no compelling research data on nicotine patches or nanokinase or any of the rest of it. It sounds good, but there's a lot of things that have been proven, and we've hit on this again: improving people's diets, improving people's lifestyles, getting the inflammatory markers down, which decrease the insult to injury that the viruses or the genetic vaccines have. Not to mention, again, vitamin C, niacin, a number of these things have been shown to be helpful with your immune system and not have an adverse effect on a human being. because these vitamins are part of what your body's made of. There's data for that. There's not for the other.
What about amino acids? I mean, if somebody, I would think that we had a talk a couple months ago. We talked about amino acids, dragon glass, the combination of these amino acids. So if somebody's now got heart damage because of a spike protein, because of a shot, multiple shots, phase one of your book in Stop Inflammation Now, which is fruits and vegetables. Amino acids, would that be helpful?
So I think the ones that were included in the protocol that I gave you are helpful for your overall immune response. So as far as helping your immune response, that's a good thing. The damage that's happening at the tissue level for the heart, for the myocarditis, is a completely separate issue. But I will also point out that there are a lot of things. I did fen-phen research for a while and published some definitive papers on that was not well received by anybody in the end, because I proved two things. One, the amount of damage done to the heart by fen-phen, phentermine drug combination used for weight loss, was greater than was being reported. So you can see that the attorneys going for the patients, they were happy with that, right? More damage, and Big Pharma wasn't very happy with that. But I went one step beyond that. I said, if we look at these same patients, which we should do, who have, quote, heart failure, weakened heart muscles, myocarditis, for example, and we treat them like we would treat any one of these patients, L-arginine or medications to lower the blood pressure to reduce the workload of the heart, what we saw was these patients got better. Well, what happened then? Big Pharma said, yay, less responsibility for us. And the lawyers for the people that were harmed said, boo, because that means less money for us. And nobody seemed to care about the patient, which should be what we're going for in the end, is the patient, not who's paying out money, but how can we best help the patient? So from the point of view of the vitamins and minerals and the healthier combination for the immune system, that's good to help your immune system. From the point of view of dealing with the myocarditis, if there's an impairment in the function of the heart, there are medications to help with that. There's even things like L-arginine to help with that. And I remember a point in time where I had other physicians who called that quackery, because L-arginine, that's not an accepted drug. And I would have to show my patients textbooks that say, well, apparently only Fleming and Mayo Clinic use this. And then I would show them published research from where Mayo Clinic had said, wait a minute, L-arginine, not only is it helpful from the antioxidant effect, but it lowers the blood pressure and allows the heart to pump better, and the patients recover. Again, it's the patients. And L-arginine, again, you don't have to go out there to somebody's website and get it. You can pretty much get these over the counter. Pay attention to what you're buying, but you don't need to pay people excessive money for the marketing of what they want to sell you. Again, I'm not trying to sell somebody the products. As you know, I'm not even good on selling these books, because I have a problem with it. This conflict of interest just wreaks havoc in my brain. And I don't want anybody thinking that I'm doing this to make money, because I'd rather end up poor, broke, and I've been homeless, so I can handle that again, than to have anybody wonder about my motives.
Okay. Next question. Somebody just emailed in. I don't know why they're not calling in, but they're emailing in. And for any of the listeners out there, all you have to do is send us an email, info@thewellnesscrusaders.com. And I have already put Dr. Fleming's, his dragon glass. I actually typed everything into a document and put all the definitions and things like that. You could do the research for yourself. I've already got it there for you. Send us an email at info@thewellnesscrusaders.com, and you can take a look at these amino acids that we've been talking about. But somebody else just emailed in and they said, why do you think so many young athletes have died on the field during soccer matches?
Right. So there's a whole slide that I put together that you've seen at these talks that puts all this information together. So as briefly as I'm able to do it, I know you're probably thinking, what happens with both the spike protein and the genetic vaccines is it interferes with the ability of calcium and potassium and sodium to go in and out of cells. And because of that, it affects how long it takes for the cells in the electrical part of your heart to recover. That means that it takes longer to recover, and your heartbeat, therefore, has to be slower. Anything that increases your heart rate, infection, trauma, physical exertion, like athletes on a field, the prion effect of the spike protein that occurs for the amyloidosis of the heart that you don't hear many cardiologists talking about because they either don't know about it or they're not a nuclear cardiologist, so they can't measure it. All of those things put together means that you cannot increase your heart rate without running the risk of your electrical system having a problem. And when your electrical system has a problem, when you try to increase the heart rate due to the damage that's been done with the movement of calcium, sodium, and potassium in and out of the cells, it increases the likelihood of you developing a very bad rhythm that will do exactly what you see on television. It will drop people to their knees. They will pass out. I could give you the terms for the rhythms, but you probably don't want to hear them. But there's a number of bad rhythms that occur as a result of the interference with the movement of the calcium, potassium, and sodium.
Okay. All right. Well, that was the final question for this episode, but tell us about your new book that is about to come out.
Right. So it will come out on Memorial Day weekend, and people can pre-order it if they want to. They can go online. It's called, as you can see, Are We the Next Endangered Species? Bioweapons, Eugenics, and More. This is a longer book. It's going to take a look at a couple thousand years of human history, but it's really going to get to the crux of the matter beginning in the 1850s in what happened in the United States and England primarily, and the changes that occurred both in the development of biological weapons and biological warfare and eugenics, as you can guess by the title. And these two fields actually merged together during the COVID pandemic, where the biological viral weapon SARS-CoV-2 and the eugenic viral genetic vaccines that were used merged together to have a consequence. It's going to walk you through some fairly uncomfortable U.S. history beginning in the 1850s, where decisions were made to basically sell medicine to the federal government and give power to the federal government to begin the development of biological viral weapons. It's going to look at the eugenics program that was going on, how we literally had court cases that were carried through that talked about sterilizing undesirable individuals to not allowing people in the United States. It was the foundation of what Adolf Hitler used. In fact, we literally provided the mechanism. The gassing of Americans was done in this country before Adolf Hitler ever thought about it. And he simply incorporated that into it. And following World War II, the United States and Russia recruited, took out the Nazi scientists and intelligence officers and brought them to this country and to Russia and incorporated them into the system. And you'll read what happened as a consequence of that. You'll get a chance to hear about my history as I was brought into the system in the 1960s, and the research, some of the research that I did, and how all of this evolved into the scenario that we're confronted with today. You'll learn about what can be done correctly, legally, civilly on the genetic vaccines. You will learn about what must be done criminally for these biological viral weapons that have been developed. You will learn about war game scenarios that you've never heard about before. I'm willing to bet on it. And one of those I'm going to walk you through is identical to COVID during the spread of the viruses, the vaccines, the food shortages, the electricity shortages. Everything was played out in this prior scenario that they learned from. And you're going to learn about legislation that I propose to be enacted in 2025. Once we get the elected individuals into place, it's a reflection on the work that I did as one of the physicians that Podesta with the Obama-Biden transition team asked me to participate in. And I took the information about what Americans were interested in healthcare, submitted it to Obama. It was completely ignored, but I'm bringing it back for proposed legislation as well, so that we can reverse these actions that have been taken by the federal government and state governments to correct science, to correct medicine, and to get us back on the path that the United States was going to be on prior to all of this. And when you think about 1850s, it means the United States only had about 75 years that it functioned as a country under the principles that we all think of before all the rest of this usurpation of power, this secret hiding, sucking up of power, taking away from the people, began to occur.
And what was your reason for naming the book like you did? Do you believe that we are the next endangered species?
So I believe that the goal of what they were doing was to produce a genetically different species. The question about whether you're endangered or not depends upon where you sit in the process. Are you going to be one of the people that are experimented upon, or are you going to benefit from what's being done? And the choices are very clear, and it's a matter of people reading and coming up to speed and then sharing this information with others and taking actions. Because if something, the losses, the military calculated losses, which I do for you in the book, is 0.8% from what has happened. From a military perspective, that's an acceptable loss ratio of American citizens to get what they want, which means they will continue to do it until they're stopped. So whether you're part of the next endangered species or not is determined by what actions you take after reading this book.
Okay. And then tell us about 10letters.org, Dr. Fleming.
So 10letters.org, and you'll see it in the book. There'll be QR codes to take you to it, as well as the code itself is a website for every American to go to, where you can enter your name and address, which you can choose to hide on the final letter, but it will then make a cover letter for your governor and your attorney general. You can download those cover letters, plus you can download the indictment letter at the very top of the page. Send the indictment letter and cover letter, one to your governor, one to your attorney general, which is a statement that you're an individual in their state, and based upon the information that's provided, you want a criminal grand jury convened to indict Fauci, Collins, a number of other people, Bill Gates. The names are laid out in the letter for their involvement in the biological viral weapons that were manufactured in violation of U.S. treaty law, in violation of federal law, in violation of a number of laws that are laid out in the book. The book actually walks a prosecuting attorney through the steps to charge these people, to show the crimes they've committed, the data that's been collected. There's about a dozen of us that are part of an expert group on this. We have more than 10,000 documents on USB drives. We have documented material on U.S. military personnel before and after being sick with the virus, before and after being vaccinated with the genetic vaccines. where we show that these elite military forces that are our special forces in all of our services were no longer able to perform at adequate levels on their endurance and physical exam tests as a result of being treated, and calls for accountability for the 1.2 million dead Americans that died from COVID, more deaths than the U.S. military has sustained since 1776, from the 1.5 million maimed Americans with the genetic vaccines, more maimed, injured Americans than the U.S. military has had injured soldiers since 1776, more than 34,000 dead Americans following the genetic vaccines, which are more dead Americans than we have lost in every war we have fought in except our 5 bloodiest wars. We have got to take action. This book explains to you what happened. It's not muddy. It's not questionable. It's documented. There's over 700 referenced documents and materials and news clippings. I will walk you through what Eisenhower was thinking. I will walk you through Truman. I think there's 13 or 14 presidents of the United States that are referenced in the materials they did. You're going to see that this pathway that people have taken in the military-industrial complex and the Nazis that were brought over got us to where we are today. We've done nothing about it, and you can see the consequences of what's happened, and they will continue unabated unless they are stopped.
I agree. They need to be stopped. And from my understanding, there's well over 10,000 letters that have already been sent out to the AGs and the governors across the United States. Who are the states leading on that?
I think right now it's very clear that Texas and Florida are leading, but it is also amazing to see how many people out of California have been sending in to the governors and governor and attorney general. Who knows how many governors they've got. But across the board, every state has been represented, and not just a few times. There are people that, accountability is a really important, and transparency. We give a lot of verbiage to that without actually doing it. And we have a tendency, we talk about this in the book too, that transparency is kind of interpreted with, if you agree with us, then you're 100% transparent. But, if you don't agree with us, well, then you're not very transparent. And agreeing with us is determined by who's running the show at any point in time. And I'm going to walk you through some very uncomfortable facts that you need to know, because whether you know them or not, they're real. They don't change. It's like gravity. You can choose to ignore it. You can choose to pretend it doesn't exist. But if you walk off the top floor of a 25-story building, gravity will make itself painfully aware to you. And as you're going down, you can say, I don't choose to believe it. I don't choose to believe it. I don't choose to believe it. I'm a tree. I'm a tree. I'm a tree. And you can say that until you hit the cement and you face the consequences of reality. And we're just going to share reality with you. Okay.
And then how does somebody find all your research and you? What's your website?
You can't find all my research, I don't think. But the website is www.flemingmethod.com. All one word, only one M in Fleming, no stuttering, just like on the book there. FLEMINGMETHOD.com. That will take you to a website. I've narrowed it down here a little bit to make it a little bit easier for people to follow. There's other things I'll put up over time, but it has, information about Fleming method, what that really means, the shift in diagnostic imaging that allows us to find problems sooner and to actually tell you whether your treatment, whatever that is, whether it's conventional medicine or diet and lifestyle or yoga meditation or just the phase of the moon, to measure whether it works or doesn't work for you, because in the end, it doesn't matter It doesn't matter if something works in 90% of the people. If you're one of the 10% it doesn't work in, the question is what works for you. Get those measurements, prove it. There's information in there about me and the garbage I've gone through in life. There's information in there about publications, and there's information about the SARS-CoV-2 viruses and things people need.
Great. That's a nice wrap. Dr. Fleming, as always, it's so awesome to be able to talk with you, get you out there to the listeners. I pray that God continues to bless your journey, and you have a good night. And thank you to all the listeners, almost 600, that stayed with us through a little bit of technical difficulties. And stay tuned for next month, third Thursday of the month, 4 to 6 Mountain Time. I don't know what time zone you are on, but stay tuned for the next interview with Dr. Fleming. Dr. Fleming, enjoy your evening. Thank you, sir.
My pleasure. Thank you so much. Thank you.